Dr. Joe, a mainstay on the Ray Horner Morning Show. Dr. Joe Congeni is live in our studio from Akron Children's Hospital. Joe, what do you have for us this morning?
Hey, Ray. You know how I always give you credit as far as the interviewer about the best-known sports medicine guy that ever interviews me from the media.
You're too kind.
You know your stuff, and so I wanted to quiz you this morning.
Okay.
I love to give quizzes. So, number one bone that's fractured in sport in teenage athletes?
My guess is the collarbone.
It's the collarbone. And the wrist is number two. Distal radius, we call it the radius fracture. But pretty now, no doubt about a collarbone related to sport. This time of year, for whatever reason, of course, sports start in August. Our emergency rooms at a children's hospital and children's hospitals around the country are filled with collarbone fractures, clavicle fractures. They happen a lot in non-athletes, and they're still treated almost always with just a sling and let it heal and so forth. But a big change about 10 years ago in athletes about more aggressive treatment early on with surgery. So I want to kind of talk, hey, let's look back now. What have those 10 years told us? But a couple of other statistics. Number one age range for sure, by far and away, 10 to 19 years of age for collarbones. They really drop off in the 20s and 30s, and you don't see them as much after that. 80% are due to a fall. Although in contact sports, it can be a direct blow. It takes quite a direct blow, but 80% are in falls. 45% of collarbone fractures are in sports. So it is a real common sport-related injury. So about 2008, I was looking back. It did surprise me a little bit. It's been a decade now. 08, 09, there started to be writing in the literature a little bit about a little bit earlier on going to fixing these surgically. And because of the fact there was an increasing, growing number of people who would break the collarbone, the two ends didn't come together. They'd end up with a big wad of bone trying to heal it. And then there might be other fractures, or they didn't heal very well, or complications. And so people started to say, again, of course, with higher level pro athletes, college athletes, let's fix this thing and see if we do better. Even on ones where it's not too bad, there's a little offset between the bones. Let's put a plate and screws in there and see what happens. And so, we're always looking for the least invasive and not having surgery done. But that was kind of what we looked at in 08, 9. I looked at a lot of articles from about 14, 15, 16 now, and it did bear itself out. It seems like in the athletic population, a few things that athletes love. Number one, it really brings that fracture better to get together much better. And we do seem to have less complications of where it doesn't heal, non-union, we call that, or refracture, where they break the bone again. Many times if they broke the bone, they'd break the bone on either side of where that big wad of where it healed. And so it would be a fracture maybe even in another area. And then the biggest thing, of course, for athletes that care so much and want to play, they could get back more readily, more efficiently, and a little bit quicker when they had it fixed surgically. And so what is that time? That's what everybody wants to know. That's what coaches want to know. That's what athletes, that's what parents ask first. Average is about 6 weeks. And so in some of the studies that I looked at last night, maybe a week of a shorter period of time, a week or two, a little bit shorter period of time when they get it fixed surgically, and it's a more reliable healing and fixing, and they get back to play a little bit quicker and less complications. And so right now, 30 years in this field, I have to change my lecture to people for so many years, 20 years. Hey, collarbones heal. We just put you in a sling. They almost all heal. Don't worry about it. Don't need to see a surgeon or anybody else. Now, if there's the least bit of offset or a fair bit of offset, we have to have that discussion with our orthopedic partners about fixing them. And it has bared itself out in the last decade. It was good for me to look that up last night and see. I think some of the reason why we made the switch 10 years ago has bared out.
Speaking of surgeries and bone breaks, I was doing some reading over the weekend, and I know it's case by case, but there's an NFL player, Derwin James, plays for the Chargers, stress fracture in his foot. And he's out, they're saying maybe 8 to 10 weeks in surgery. And then I was reading another offensive lineman who has a stress fracture in his foot, and he's going to play next week. So these stress fractures with these big guys playing football, and I'm sure you see it at the high school level, well, Is there a wide range of difference in these stress fractures that we're seeing in the foot?
No doubt. And thank you for queuing me up. Just right on. You put it right on the tee for me and everything else, because that is 15 to 20% of a practice of sports medicine is stress fracture. So if you open our door and what walks in a pediatric adolescent clinic, it's going to be stress fractures are 15 to 20%.
Wow.
And the whole thing is related to what bone is it. The vast majority of the bones where we see stress fractures are 4 to 6 weeks of relative rest. Get them cross-training so they're not losing their fitness over that period of time. Get them on a strengthening program. Check and see if there's any mechanical problem with the way they run and things. And they're usually back within. They're knocking on our door in a month saying, hey, I'm ready, 4 to 6 weeks. There's a few bones that are bad. I call them snake in the grass. There's just a handful. And one of them in the foot is the fifth metatarsal. It's known as the Jones fracture. In Cleveland lore, it's known as the Jones fracture. So it probably cost us an NBA championship in the Miracle of Richfield. Jim Jones was the center. He broke his foot with a Jones fracture. He had to have the pin placed. And when you have that pin placed, it's 12 weeks. It's more like a couple of months period. That's one of the bad bones. Other bad bone, there's a bone higher up in the instep of the foot, and it's called the tarsal navicular, and it's called in Cleveland lore the Zadrunas foot problem. So remember all the problems Zadrunas had all those years we paid him and he wasn't playing for us? He had a navicular fracture. So in sports medicine, we got to know location, location, location. It's all about what bone it's in. The rest of the metatarsals in the foot, they heal in a month, 4 to 6 weeks, relative rest, a little bit of time in a boot, and they heal real well. If you get one of those in the bad area where, unfortunately 2 of the calves I mentioned, there's a few other areas in the body that are bad bones to get a stress fracture in. But I know that's a head scratcher for athletes too. Hey, what about that other guy's back, so much quicker, and you're doing surgery on my foot? It all depends on the healing rate, and we learned that through research. And this collarbone information, clavicle information was really good to review today.
Good stuff, Joe. Thank you very much.
Okay, thanks, Ray. Have a great week.
You too. Dr. Joe Congeni, Akron Children's Hospital with us.